Okay, so hello and welcome. Today's topic is subarachnoid hemorrhage. Before moving any further, I would like to give you a heads up to this topic and briefly overview what we are going to learn today. So basically starting with the image itself, this is a CT head image wherein it is showing a star-shaped hyperdensity, classical of subarachnoid hemorrhage. And the other two images are angiographic images wherein a berry aneurysm is being shown. And after the procedure called endovascular coiling, this berry is obliterated, which is also a definitive treatment for subarachnoid hemorrhage. But looking at the lethality of this disease, approximately 35% of the people, even before reaching the hospital, die and not able to get the primary treatment even. Also, subarachnoid hemorrhage has its own delayed neurological effects, which we will see. All the features, such as sudden in onset, excruciating headache, the patient might say the worst headache of his life, are all the features suggestive of subarachnoid hemorrhage. So, before you even evaluating a person with headache, the first and the foremost thing that a physician should look for is if the headache is of sudden onset and severe in nature, must first rule out subarachnoid hemorrhage. Okay, going into the topic proper, but before that, these are all very much similar looking CTs. Starting with the first one, which is an epidural hematoma. Okay, so this lens-shaped hyperdensity is suggestive of epidural hematoma, and the source of this blood is arterial, and the patient will have symptoms of lucid interval wherein the person will be on. So the most common cause of epidural hematoma will be a road traffic accident. The patient will be conscious, awake. He will himself reach the hospital, and on reaching the hospital he might then go into a state of unconsciousness. That is lucid interval, typical with epidural hematoma. Differentiating it from subdural hematoma. Subdural hematoma is crescent shaped hyperdensity as shown in this figure. It is crescent in shape. The blood is venous blood, and the person will complain of progressively worsening headache over a period of time. But then also with chronicity, this hyperdensity might turn into hypodensity, suggestive of chronic subdural hematoma. Our topic of interest, subarachnoid hemorrhage, shows this classical star-shaped hyperdensity. Actually, this is a subarachnoid space wherein our circle of Willis is present. So, any rupture of blood vessel there will ultimately lead to accumulation of blood anywhere the subarachnoid space is present. So, a star-shaped hyperdensity. Though the causes we will discuss, here I have written AV malformation, but trauma and rupture of berry aneurysm are the causes of subarachnoid hemorrhage. And classical, the feature is thunderclap headache, or the patient may say that he had the worst headache of his life. And lastly, we have intraparenchymal hemorrhage, as such seen in stroke patients. The shape can be any. The source of blood is arterial, and the features may be loss of consciousness, seizures, mass effects, and effects related to hydrocephalus. Okay. Understanding how the subarachnoid space is and what all structures does it hold and why is it clinically important for us to learn about it. So looking at the sagittal image on the left, we have this light green demarcation. It shows subarachnoid space. So the subarachnoid space contains CSF. Where does this CSF come from? CSF comes from this choroid plexus. Choroid plexus forms the CSF and is drains into the lateral ventricles. From lateral ventricles, there is this foramen. From that foramen, the CSF drains into the third ventricle. From there, via the cerebral aqueduct, it moves into the fourth ventricle. And from there, there are foramen luschka and foramen magendi. The CSF leaks into this basal cisterns. That is how the Basal cisterns also have the CSF. And going down, the CSF continues flowing below and continues in the subarachnoid space, even in the spinal cord segment. Then where does the CSF flow? That I have already answered. And where does CSF drain into the blood? So basically the CSF will flow in this cisterns and this space, and there are these arachnoid granules. From there, the CSF will ultimately drain into this dural venous sinuses and into our venous system. So that is how our CSF flows, and I have tried to explain the subarachnoid space. The most important part before even starting subarachnoid hemorrhage is understanding circle of Willis. So I will basically try and annotate. So these are our vertebral arteries, which gives one branch. Its name is posterior inferior cerebellar artery. Then it forms the basilar artery. Two vertebral arteries merging together forms the basilar artery. It gives its own branches, also known as pontine branches. Okay. Then the top of the basila, wherein the posterior cerebral artery is originating, and this is superior cerebellar artery. So if we look at this image, then we can understand that there were two vertebral arteries merging together, moving in front of the brainstem, and then ultimate this is the basilar artery going ahead, and then forming the uh, forming the posterior cerebral and superior cerebellar artery, and on the way giving also here I will note, this is ICA, anterior inferior cerebellar artery. Okay. Then from the anterior circulation part, here comes the internal carotid artery. This is the internal carotid giving off middle cerebellar artery branch, and posteriorly this is the PCOM, posterior communicating artery. Then ahead this is the anterior cerebral artery, and this is the ACOM, anterior communicating artery. Okay. So why is it important to know the exact anatomy of circle of Willis? Because aneurysms, particularly aneurysms, the most common sites are the top of the basilar artery at the bifurcations of the ICA and the MCAs. These are the three prime locations where the aneurysms are going to be. Hence, whenever these aneurysms are going to be get enlarged or ruptured, the structures nearby these arteries or structures nearby these vessels are going to be affected. As for example, there is third cranial nerve palsy. I will write it down here. Third cranial nerve palsy with aneurysms related with PCOM, posterior communicating artery. If you can see closely, posterior communicating artery is here. Okay. And attaching itself with the posterior cerebral artery, and here only at the brainstem, at the midbrain, the third cranial nerve originates and it moves forward. So any aneurysm at the PCOM location is going to disturb or compress on the third cranial nerve, and it will lead to its features. Okay. I think I am clear by now. So what are the causes of subarachnoid hemorrhage? Harrison says excluding trauma, the most important cause is rupture of berry aneurysm. Therefore, the most important cause and the most common cause is trauma. The second common cause is rupture of berry aneurysm. The third is AV malformations. It can be congenital, it can be acquired. The fourth is intracranial hemorrhages extending into the subarachnoid space. And lastly, the idiopathy. So, discussing about the berry aneurysms. First of all, we must understand why the aneurysm was formed in the first place. Why? So, basically, the patient might have risk factors such as hypertension or say smoking history, or any genetic conditions wherein the arterial wall becomes weak and it leads to the outpouching of the artery. So here I have tried to show there is the various layers of an artery. So the innermost layer is the endothelium. Outside it is the internal elastic lamina. Outside of it is the tunica media, which is the muscular layer. Outside it is the external elastic lamina, and finally the tunica adventitia. So for a berry aneurysm to form, it must contain all the layers of the arterial wall. Hence, if you can see in this image, this is a secular aneurysm being shown. There is an outpouching containing all the layers of the artery. As I said, risk factors such as hypertension, smoking, and genetic conditions can lead to weakening of the arterial wall, and a berry aneurysm can be formed. Now, with respect to subarachnoid hemorrhage, when a berry aneurysm ruptures, there are a striking 35% mortality overall. The patients presenting with a rupture of berry aneurysm, the striking 35% mortality. And of them, approximately one third patients die immediately and before reaching the hospital. Even if the person survives and the aneurysm is not obliterated, the rate of rebleeding is 20% in first week and 30% in the first month. So, such is the severity and such is the promptness required from the physician's aspect. We must be prompt in identifying and treating. Then we must understand what are the common locations where this berry aneurysm will be formed. Harrison gives this diagram wherein it marks these four locations, which are all these four locations are in the anterior circulation part. Though the fifth one is also a common site. The fifth one, as you can see, is the top of the basilar artery. Okay, so this was the basilar artery, the top of the basilar artery, wherein the aneurysm is the form, one of the common site. Then this is the middle cerebral artery. It is also a common site wherein aneurysm will be formed. And terminal ICA, internal carotid artery, is also a common site where the aneurysms will be formed. It is not that only one aneurysm can be present. Multiple aneurysms can be present in a single individual. And Harrison says approximately 2% of the population harbors aneurysm, which can be asymptomatic and not being problematic. Pathophysiology. As I said, like weakening of the arterial wall leading to the formation of this aneurysm, the risk factors can be hypertension, smoking, or genetics. So, but then for subarachnoid hemorrhage to happen, this aneurysm has to rupture, and with rupturing of this aneurysm and leaking of the blood is the way how our pathophysiology progresses. Leaking of this blood compresses on the brain parenchyma, leading to its effect, forming a hematoma, giving us specific symptoms, and also there is vasospasm associated with rupturing of the aneurysm. So, secular aneurysm occurs at bifurcation of large arteries, and 89% of the aneurysms occurs in the anterior circulation. Okay, and there is one peculiar thing to note here, that the aneurysm has both a neck and a body and a dome. So the length of the neck and the diameter of the dome are important factors in planning neurosurgical obliteration and endovascular obliteration. Okay, clinical manifestations. Just I would like to reiterate this highlighted things. So there is a sudden and a transient loss of consciousness in 10% of the people. Then brief moment of excruciating pain, and also approximately 45% of the people are going to present with the complaint that they have severe headache with exertion. Patient may often call it as the worst headache of their life. The most important characteristic is its sudden onset. Any person with sudden onset severe headache must be evaluated for subarachnoid hemorrhage. The headache is usually generalized with neck stiffness and vomiting is also associated. Then clinical features, as I said, with because of the formation of hematoma, compressing on the brain parenchyma, causing mass effects, causing hydrocephalus. These are all the symptoms with subarachnoid hemorrhage. Neurological deficits, as I said, a third cranial nerve palsy, as PCOM aneurysms are common, and if that aneurysm ruptures, that the patient can have third cranial nerve palsy, such as drooping of eyelid, dilated pupils, okay, down and out eyeballs. Such are the features of third cranial nerve palsy. Sixth cranial nerve palsy can also occur because internal carotid artery goes through the cavernous sinus. If there is an aneurysm in the internal carotid artery and it occludes the cavernous sinus, the sixth cranial nerve passes through the cavernous sinus. Therefore, sixth cranial nerve palsy features can also be present. So these are the broad clinical features associated with subarachnoid hemorrhage. So the bottom line is sudden, unexplained, severe headache at any location should raise suspicion of subarachnoid hemorrhage and must be investigated. Uh, Subarachnoid hemorrhage, though it presents acutely, it also has delayed neurologic defects. The person will be having symptoms after, say, 4 to 7 days of onset of headache. So there are four major causes of delayed neurologic defects. The first is re-rupture. Understandable that if today the rupture of berry aneurysm occurred and it was not obliterated, there are 20% to 30% chances in the first month that it will re-rupture and the symptoms will occur. The second is hydrocephalus. If subarachnoid hemorrhage is so extensive, it leads to diminished absorption of CSF, occluding the CSF space and thereby leading to hydrocephalus symptoms. If there is acute hydrocephalus and the patient is stuporous or in comatose state, external ventricular drainage or ventriculostomy is done. Then, if this hydrocephalus develops over a period of time, the patient might have symptoms such as progressive drowsiness, progressive worsening headaches, gait difficulties, incontinence, memory impairment. In such cases, ventriculoperitoneal shunt may be required. So, we must look for the features of hydrocephalus on subsequent days following subarachnoid hemorrhage. The third and the most important is the delayed cerebral ischemia following subarachnoid hemorrhage. We will discuss this in other slide. And lastly, hyponatremia. Patients with subarachnoid hemorrhage are prone to develop hyponatremia, and therefore correction of hyponatremia is also needed. Discussing about delayed cerebral ischemia, approximately 30% of the patients of subarachnoid hemorrhage develop delayed cerebral ischemia. That is, following subarachnoid hemorrhage, there is vasospasm leading to cerebral ischemia and even infarction. Signs of delayed cerebral ischemia first appear 4 to 14 days after the hemorrhage. So, if you can understand, the episode occurred, and then after 4 days, 4 to 14 days, this ischemia kicks in. Therefore, the patient with subarachnoid hemorrhage, if surviving, must undergo transcutaneous Doppler ultrasound on either daily basis or every alternate day, which can reliably detect this vasospasm if going on. So, by directing the probe along the middle cerebral artery, anterior cerebral artery, carotid terminals, vertebral artery, and basilar artery. Okay. And then CT angiography is also another method to detect cerebral ischemia if going on. Hyponatremia. Hyponatremia is such that there is natriuresis plus there is hypovolemia. So it is an hypovolemic hyponatremia going to develop in a patient of subarachnoid hemorrhage. Atrial natriuretic peptide and brain natriuretic peptide both have a role, and they classically show like cerebral salt wasting syndrome. Therefore, as this patient is having hypovolemia, You do not ask the patient to go for water deprivation. It is strongly contraindicated. We must slowly correct the sodium levels so as to prevent the patient from developing osmotic demyelination with the help of 3% NaCl as per the body weight. Laboratory evaluation and imaging. The hallmark of aneurysmal rupture is the blood in the CSF. But 95% of the cases of subarachnoid hemorrhage will be easily seen on a CT head. Such is the specificity and sensitivity. So this is a CT head shown here on the left corner, wherein it shows a star-shaped hyperdensity, classical of subarachnoid hemorrhage. If the CT head is not conclusive and the suspicion of subarachnoid hemorrhage is high, and if there is no any mass lesion or hydrocephalus, then we can go in and perform lumbar puncture. This is the image of CSF fluid following a lumbar puncture, which shows this yellowish tinge of CSF fluid, also known as xanthochromic CSF, xanthochromic spinal fluid, which is a characteristic of subarachnoid hemorrhage. Once the diagnosis of subarachnoid hemorrhage is done, then the patient must undergo a four vessel X-ray angiography. This is the image of an conventional X-ray angiography, wherein if I can zoom in, I would like to show you that uh, on the right side there is this berry being shown here, and the same berry is been obliterated with the help of coiling. So diagnosing subarachnoid hemorrhage and then following that patient with an X-ray angiography is a must to localize and define the details of the aneurysm, like how big is it is, what is the length of the neck of the aneurysm. Okay, then, like as I said, if there is no mass lesion and no hydrocephalus, only then you can perform lumbar puncture in patient of subarachnoid hemorrhage. So for that, we must understand what are the indications and contraindications related to lumbar puncture. So here this image shows various layers through which the lumbar puncture needle is goes through and ultimately reaching the subarachnoid space, and we take out the CSF fluid. So the first layer is the skin, the subcutaneous tissue. Then this is the supraspinous ligament which we pierce. Then in between the vertebral bodies is the interspinous ligament. Lastly is the ligamentum flavum. Then we pierce the dura mater, and then ultimately piercing the arachnoid mater, we reach the subarachnoid space. What are the indications? Indications are many, like infections, meningitis, encephalitis, multiple sclerosis, GBS, subarachnoid hemorrhage, uh, intrathecal chemotherapy agents, antibiotics. So these are all the indications. But important than that is understanding the contraindication when not to do lumbar puncture. Absolute contraindication is increased intracranial pressure due to a mass lesion. If at all there is any mass lesion seen on a CT, do not perform lumbar puncture because it can lead to herniation of the brain. Second is local infection at the puncture site if the patient is hemodynamically unstable. Relative contraindications are coagulopathy or bleeding disorders, platelets less than 50,000, if is there any spinal deformity or the patient is on anticoagulant use. Treatment. Treatment includes early aneurysmal repair. It prevents re-rupture and also delayed cerebral ischemia is being prevented. We have two methods for treating aneurysm. One is by clipping, the other is by coiling. Clipping the neck of the aneurysm is done by a neurosurgeon. Coiling with the help of the endovascular coiling technique done by an endovascular surgeon. So in many centers, this definitive repair is being done within 24 hours of bleed. So, but this is the definitive treatment. Before that, we must have medical management, which includes protecting the airways of the patient, managing the BP. If the patient is alert and awake, the BP, the systolic blood pressure of the patient should be uh, below 160 millimeters of mercury. Treating hydrocephalus. If there is hydrocephalus, we need to insert external ventricular drainage, also known as ventriculostomy, and relieving the pressure. Subsequently, after the definitive aneurysmal repair, we need to prevent vasospasm. Delayed cerebral ischemia has to be looked for, and treating hyponatremia. Stuporous patient should undergo ventriculostomy in order to measure, treat the intracranial pressure, and prevent herniation. In this case, lumbar puncture is contraindicated. Better to go with ventriculostomy, because ventriculostomy will have we will like in a controlled fashion the CSF is going to be draining out. Prior to definitive treatment, adequate cerebral perfusion pressure has to be maintained. So I would like to comment here that cerebral perfusion pressure is equals to mean arterial pressure minus intracranial pressure. So this is the formula. If the patient is hemodynamically unstable, it is he is in shock, or the mean arterial pressure is low, the ultimately the cerebral perfusion pressure is low. We must maintain the cerebral perfusion pressure at all the times. Okay, so for alleviating mean arterial pressure, we can use plasma volume expanders or nor like vasoactive agents such as noradrenaline. Okay, if at all the patient with subarachnoid hemorrhage presents with seizures, those seizures are somewhat not oftenly present, but if the patient presents with seizures, Harrison says usage of levetiracetam is good, and phenytoin must be avoided. Usage of glucocorticoids. Is there any use of glucocorticoids in subarachnoid hemorrhage? The answer is no. There is no evidence related to its effectiveness in subarachnoid hemorrhage. Delayed cerebral ischemia remains the leading cause of morbidity and mortality. Therefore, we cannot overlook this delayed cerebral ischemia and has to be treated with calcium channel blocker, that is nimodipine, 60 mg per oral every 4 hourly. So the cycle goes like this, that symptomatic cerebral vasospasm, treatment with increasing the cerebral perfusion pressure. How are we going to increase the cerebral perfusion pressure? By increasing the mean arterial pressure. How are we going to increase the mean arterial pressure? By giving IV vasopressors or plasma volume expanders, and therefore achieving the euvolemia. Euvolemia is the target. If this vasospasm still persists, then our other option is endovascular rescue therapies, which includes percutaneous transluminal angioplasty. Here in the image, it is shown that on the left hand side, this internal carotid artery giving off the middle cerebral artery is showing spasm, a diffuse spasm. Then on this right sided image, it shows with the help of this angioplastic technique, the middle cerebral artery is opened up and the symptoms are relieved. So this is the other mechanism. And lastly, all patients with subarachnoid hemorrhage should have pneumatic compression stockings applied to prevent the pulmonary embolism part. And when the patient has undergone a definitive repair, then the patient should be taken on unfractionated heparin or low molecular weight heparin for DVT prophylaxis, initiated within 1 to 2 days following endovascular treatment. So I think this was all about subarachnoid hemorrhage. And lastly, I would like to end this today's video with the simple MCQ. So we'll read this first, and I'll give you 5 seconds to 10 seconds for the answer it on by yourself. A 48-year-old woman presents with sudden onset severe headache, described as the worst headache of her life, followed by vomiting. CT brain shows diffuse subarachnoid hemorrhage with acute hydrocephalus. She is drowsy but localizing to pain. Which of the following is the most appropriate next step in the management? The option A is therapeutic lumbar puncture to reduce intracranial pressure, mannitol infusion followed by observation, external ventricular drainage, immediate CT angiography followed by surgical clipping, high dose corticosteroids to reduce cerebral edema. Yes, by this time, I think everybody has are ready with their answers, and the likely answer is C. As we have read, likely answer is external ventricular drainage. Why? Because the patient is having hydrocephalus, which is a contraindication to performing lumbar puncture. And if the patient is drowsy and we don't know the osmolarity related with, okay, so I think sorry, and so we cannot blindly infuse mannitol, and immediate CT angiography followed by surgical clipping. So, but then reducing the raised intracranial pressure, the best way is by external ventricular drainage. And high dose corticosteroids is contraindicated. It is of not much use. Okay, so this was it, guys, and I think yes. Thank you, and thank you for listening me. Thank you so much.